السلام عليكم جميعا. Good evening everyone. My name is Alaa Dos. I'm head of medical affairs for oncology in Newbridge Pharmaceuticals. First of all, I would like to thank Yushid for inviting Newbridge today for your meeting. And in Newbridge, as an oncology regional team, we are always proud to support you and support your patients, especially those who are suffering from HCC. And today, we will have very interesting, elegant discussion on some of the recent updates on management of HCC in Egypt. Thank you again. And I would like just to hand over to our moderators, Dr. Mohammed Negm and Dr. Kordi, to take over the meeting. Thank you so much.
Thank you. Thank you, Dr. Alaa. It is our pleasure to have you today with us, and thanks to Newbridge. Ladies and gentlemen, today we have our third wave, the third Yushid wave for updates on HCC. We're going to have fruitful talks. We're going to have a very good discussion with our experts. So please allow me to welcome my dear professor, Professor Gamal Al-Asmat. He's a professor of hepatogastroenterology and infectious diseases, WHO STAC member. Professor Asmat is the former vice president of Cairo University, the Egyptian Nile Award in Science in 2016. He also got the State Merit Award in Medical Science in 2010, and he is the past president for the International Association for Study of Liver Disease. Welcome, Professor Asmat, and let's start with your introduction.
Bismillah ar-Rahman ar-Rahim. I wish to thank Dr. Negm for his kind introduction, and it's my pleasure to be with you today. I will talk briefly about the problem of hepatocellular carcinoma in Egypt. It is a challenging tumor with high incidence and, sorry enough, high mortality rates because most of the cases are seen in a late stage. This is the data that we have from the results of the National Population-Based Cancer Registry Program, and it was published in 2014 about the situation of malignancy in Egypt. We can see that liver malignancy is about 1/4 of all the malignancy in Egypt, followed by the breast cancer and the urinary bladder cancer. This is in both genders, but if we go to males, we notice that the hepatocellular carcinoma is about 1/3 of the cases of the malignancy. And if we talk about the risk factors for hepatocellular carcinoma all over the world, alcohol, HPV, HCV, and others. And if we go more details about North Africa and Middle East, HCV is responsible about 44% of the cases of hepatocellular carcinoma, but the situation in Egypt is different. In Egypt, most of the cases of hepatocellular carcinoma are due to complication of HCV. You can see a lot of publications here, and hepatocellular carcinoma following HCV infection range between 75 to more than 90%. And it is known that the annual risk of developing of hepatocellular carcinoma after developing of cirrhosis due to HCV is between 2 to 8%. And once hepatocellular carcinoma developed, the rate of cumulative recurrence is known to be approximately 70% over 5 years. So we are facing a big problem of HCV in Egypt, leading to a big problem of hepatocellular carcinoma. When we put our strategy in 2013 to manage HCV infection, we have 3 scenarios. If we, at 2013, if we were treated the same patients, 65,000 patients per year, with the success rate of about 50%, because at that time we were using the pegylated interferon, or the second scenario, if we are giving the direct antiviral agents with a success rate is about 90%, but the same number of patients is treated annually, or the third scenario, the best scenario, to have a success rate more than 90% and to treat more than 325,000 per year. And this last and best scenario will lead to decrease on the infection by 95%, decrease in compensated cirrhosis by 88%, decrease in the decompensated cirrhosis by 87%, and which is important to us in this talk, decrease in hepatocellular carcinoma related to HCV by 85%. Another study which was done in American University in Cairo, saying that the rate of hepatocellular carcinoma will continue and maybe increase if you are treating HCV patients, only 125,000 HCV patients per year, and it will decrease if you treated 500,000 cases per year, but the market decrease will be seen if you treated about 1 million cases per year for more than 4 years. And this is what we did in our program. We were able to start treating patients by direct antiviral agents, but after we treated them by pegylated interferon and ribavirin, which was the standard of care at that time, we started by direct antiviral agents for all patients. We treated more than 600,000 patients in year 2016. Even we don't have any patients on the waiting list. This is why we started our presidential initiative of screening of all citizens above 18 years of age, and we screened about 60 million subjects, looking to those who have HCV antibody, starting to treat them to prevent them from developing cirrhosis and developing hepatocellular carcinoma. This was the chart for the prevalence of HCV in Egypt in 2008. It was 15%, and it decreased in 2015 to 10%. And in 2018, when we started our program for national survey, national screening, it was 5%, and we treated all patients. And now I think we didn't do, but I think it is less than 1% nowadays. Why? Because we screened about 50 million patients, 50 million citizens, and we found that the prevalence is 4.6, and we treated all these patients free of charge. Even all the investigations, the treatment were free. And this data was published in the New England Journal of Medicine last year about this big program of screening and treating patients with HCV. Of course, we are facing another problem about the relation between hepatocellular carcinoma and direct antiviral agents. All of us know that direct antiviral agents are not carcinogenic by itself, because if we treated patients that didn't have cirrhosis by direct antiviral agents, no one developed hepatocellular carcinoma. But what about the cirrhotic patients receiving direct antiviral agents? There is conflicting results. And in Egypt, we have many data that we can show it with you, but I will give only a summary about this mini review looking to the recurrence or the occurrence of hepatocellular carcinoma after treating cirrhotic patients with direct antiviral agents. And of course, there is still debate, but it is very important for us to know that if we treated patient with HCV-related cirrhosis from HCV, we must continue our surveillance for early detection of hepatocellular carcinoma even after sustained virological response and cure from HCV. And this is why we started our Egyptian National Program for Hepatocellular Carcinoma Surveillance on September 2019, just before the COVID epidemic. And we said in this program that we will offer free alpha-fetoprotein test and free ultrasound examination for those who are F3 and F4 by FIB4 or by FibroScan. And this will be done every 4 months. We have 72 surveillance centers. We have 63 CT referral centers. We have 30 MRI referral centers. and we have 20 centers for treatment of patients with HCV MDT centers. And even with this epidemic of COVID, most of our centers were able to have the target for enrollment. Only 5 centers from the 72 have less than 50% of the target, and 5 centers have between 50 to 70% of the target, but most of our centers have the target more than 70%, and 23 centers have the target more than 90%. And due to this, we were able to recruit about 80,000 patients with cirrhosis after treatment by direct antiviral agents, and we did ultrasound and alpha-fetoprotein for 73% of them, and we found focal lesion or elevation of alpha-fetoprotein in 3,000 of them, and they were referred for CT or MRI, and we discovered hepatocellular carcinoma in about 821 cases of this. It's about 1% of those who have been screening, and it is about quarter of those who have referred to CT or MRI. 654 referred to treatment, and about 50% of them already finished their treatment. And we can notice that the prevalence of hepatocellular carcinoma is less than 2%. It is only 1%. And we can notice that also that most of the cases which were discovered, we were able to treat them because we discovered them in an early stage, as we will see in this slide. Most of the cases were child A or child B, only 20% are child C, and number of focal lesions, most of the focal lesion was only 1 or 2%, only about 20% have 3 focal lesions or more, and the size of the focal lesion was less than 3 centimeters. In most of the cases, more than 80%, we discovered focal lesion less than centimeter that we can deal with them very accurately. So this was very good for us that we discovered these cases very early, and this means that we can have and deal with these cases very well. This is why we said that surveillance and screening is very good for us. And I will finish here my presentation, and thank you all. And I wish to invite all of you to attend the USHID meeting on the last day of September this year, and also it will extend for another 2 days on October. Thank you very much.
And now we are moving to the second speaker. We have Professor Iman Barakat. Professor Iman, she's Professor of Tropical Medicine at Ain Shams University, and she's the Vice President of the Hepatoma Group at Ain Shams University, and the Vice President of the Egyptian Society of Liver Cancer. And as Professor Ismat has stated, we are still facing a lot of cases with advanced HCC, so we need to know more about the systemic therapy of HCC. And now we are waiting for Professor Iman to talk about systemic therapy of HCC as an ever challenge. So please, Dr. Iman, go ahead.
Thank you, Dr. Kordi, for this nice introduction, and thank you, Sheet, for allowing me for this talk today. My talk titled Systemic Therapy of Hepatocellular Carcinoma, which is an ever challenge. Why? You will see. Hepatocellular carcinoma is a universal health problem, and it's one of the most common malignant tumors and account for approximately 90% of all primary liver cancer cases, and it's associated with a significant clinical, economic, and psychological burden. As you see, the liver cancer presented the 6th most common malignancy worldwide and the 3rd leading cause of death among cancer patients worldwide. In Egypt, our popular or the highly popular country, hepatocellular carcinoma is a local health problem also, and as Professor Dr. Gamal said, it takes almost the first place in all cancer regarding the incidence and the death rate. This is the annual number of HCC cases per year in our group, the hepatoma, the Ain Shams group, which started since the 2002, and we have seen about 6,000 HCC patients in our HCC outpatient clinic, and this is the number of patients along all those years, starting from the 2002, ending by the 2017, with male incidence much more than female incidence only 15%. And as Professor Dr. Gamal said, in our group, we found the same data that HCV is the underlying cause of cirrhosis, and subsequently the incidence of hepatocellular carcinoma among our patients, more than 93% of patients having HCV as an underlying etiology. And here's the child class of our patients. 50% of our patients presented with class A, and the other 50% for the B and C. Regarding the BCLC stage of the tumor, early HCC represented only in 25% of the cases at the time of diagnosis, while the majority of patients have advanced HCC, 40% at the time of the presentation. So what's the definition of the advanced stage of HCC? According to the BCLC staging system, which is the most acceptable by most of the guidelines for treatment and diagnosis of cancers, the advanced stage lie here, advanced stage C, with the patient presented with either portal vein invasion together with the tumor, extrahepatic spread, or performance status 1 to 2, and those patients amenable only for systemic therapy. And actually, a significant number of patients with intermediate stage B not suitable for chemoembolization treated also by the systemic therapy. So most of the HCC cases are detected at advanced stage or incurable stage, where the overall survival for many of these cases doesn't exceed 1 year, and the systemic therapy is the current standard of care for this advanced stage, which including the molecular, target therapy, and immunotherapy. This is illustration for the first and second line treatment that approved as a systemic therapy. And as you see here, sorafenib, which was approved at the 2007, remained for almost a decade the only systemic therapy for hepatocellular carcinoma. And from the start of the 2017, other drugs have been approved in the first line, Atsubiva, Lenvatinib, Pembrolizumab, Lenvatinib, and in second line, regorafenib, nivolumab, cabozantinib, Lemiro, and Pembro, and other have been approved as a treatment for hepatocellular carcinoma. The sorafenib, which is the multi-target tyrosine kinase inhibitor, have been approved according to those trials, the SHARP trial and the Asia Pacific trial, with the median survival in the sorafenib arm in both studies is longer than that for the placebo. Again, in the current first line, Lenvatinib, which is the multi-target inhibitor that suppresses vascular endothelial growth factor receptor, fibroblast growth factor receptor, and a platelet-derived growth factor receptor alpha, as well as DACET and RET oncogenes. Also, Lenvatinib had other effect, which an immunomodulatory effect on the tumor microenvironment, rendering the tumor more liable for the action of immune check inhibitor, so that make the lenvatinib suitable for combination with other dose drug, adding more potent anti-tumoral efficacy. The lenvatinib was approved according to the REFLECT trial, which is a phase 3 trial to compare the efficacy and safety of lenvatinib versus sorafenib in the first-line treatment of patients with unresectable hepatocellular carcinoma. And it was approved to have a longer overall survival and progression-free survival and time to progression, and even more tumor shrinkage than the lenvatinib, than the sorafenib arm. And regarding the health-related quality of life, the impact of health-related quality of life was generally similar between lenvatinib and sorafenib. And here is lenvatinib combination, which was approved, lenvatinib plus Pimprio at the year 2019, with median overall survival 22 months. I think this is a good result. Lenvatinib upcoming studies is more and more together with the other drugs. This is our ongoing studies. Again, in the first line, combination therapy, the Adsupeva. The Adsupeva combination has recently approved by most of the guidelines. Here, the overall survival in the Adsupeva are 19.2 versus 13.4 for sorafenib. Now shifting for the current second-line therapy for advanced stage disease, daregorafenib, which is more potent multikinase inhibitor than sorafenib, and approved at the year 2017 according to the resource trial. This drug is taken for patients who progressed on the sorafenib but intolerable for the drug, with longer overall survival as here. Again, the second line, cabozantinib, the multikinase inhibitor with potent inhibitory activity, approved at the year 2017 for the patient who progressed on to up to priority therapy, prior systemic therapy that make the cabozantinib amenable for to be a second line and also a third line treatment. Other drug that available for the second line, ramucirumab, the polyhumanized recombinant IgG monoclonal antibody targeting the vascular endothelial growth factor receptor, and approved at the year 2019 and used in specific for patients with alpha-fetoprotein more than or equal to 400 nanogram per milli who had intolerance or progressed on sorafenib therapy. Again, with the second line, nivolumab, with the first immunotherapy in the human programmed this receptor blocking antibody, approved in the year 2017 and achieved improved overall survival, objective response rate versus placebo in HCC patients. Here, the incidence of grade 3 or more adverse events with most of the protein kinase inhibitors. As you see here, the hypertension is the most common with lenvatinib, while the hand, foot, and skin affection is more with the other tyrosine kinase inhibitor. Now we come to important point, why this hepatocellular carcinoma and its therapy in the advanced state is a challenge. This is because of the presence of the underlying disease. The patient is not affected only by the tumor, but also by underlying liver disease, which is cirrhosis. And at the time of the presentation, as you see here, child B represent 60% of patients with Barcelona stage C. And most of the patients treated by the systemic therapy should be of child A or early B, and this is a challenge. Other challenge is the drug resistance. The drug resistance is because either interpatient heterogeneity, so each patient is a story by himself, no one like other. Again, the tumor itself, there is intratumoral heterogeneity. And regarding the drug, when the drug coming and enter the environment of the tumor, change of the tumor occurs so that the primary tumor is quite different from the de novo lesions or from the metastatic lesion. Again, another problem in the drug sequences and a choice. Different guidelines have adopted many of those drugs, classifying them. But there is a lot of drugs and a lot of differences between the guidelines. Regarding the EASL and even the ESLD, until the year 2018, sorafenib, lenvatinib for the first line, and those for the second line. This is quite different from the NCCN guideline, which preferring the ensopeva as a first-line regimen and alternative in the first line, sorafenib and lenvatinib, and even nivolumab, put it in the first line, and all those drugs in the second line. Also, for the ASCO, put ensopeva, lenvatinib, and sorafenib at the same level of choice, and the other here, including pembryo and nivolumab, as a second line. And those are the drugs recommended by the ESMO for the first line and second line, and even cabozantinib and ramucirumab suggested as a third line of treatment. So, which drug to be chosen for the patient? Should I choose sorafenib?
Thank you so much, Professor Iman, for your elegant presentation. And we're sorry that we lost you before the conclusion. And now I think we're going to shift to Professor Amit Singhal. I'd like to welcome him today with us. He's our guest speaker. Professor Singhal is Professor of Internal Medicine, Department of Internal Medicine at University of Texas, Southwestern Medical Center. In 2017, he was awarded an award for excellence in liver cancer research and got the David Bruton Professorship in Clinical Cancer Research. Now he is the co-leader of the Simmons Cancer Center Population Science and Cancer Control. Welcome, Professor. We're so happy to have you with us today. So let's join him now for his presentation.
Thank you so much. Quite honored to be part of the program and follow the two excellent talks that we've already heard. As you can tell from the title, the purpose of my talk will really be to focus on lenvatinib and really discuss how we go from the clinical trial data in REFLECT to applying this to clinical practice. So as you heard from just the last talk, we've really had systemic therapy options now proven for HCC for approximately 13 years. And this really started with the SHARP and the Asia Pacific trial when sorafenib was the first systemic therapy that was shown to have a survival benefit for patients with advanced stage HCC. As you heard, the SHARP trial took patients with advanced unresectable HCC, randomized them to receive sorafenib at its typical dose of 400 twice daily or placebo. And sorafenib was shown to have a significant benefit, a 31% reduction in mortality. Median survival with sorafenib right around 10.7 months and placebo 7.9 months. This was published in the New England Journal in 2008. And I remember when this came out, we thought that we were at the cusp of having many new agents come to market shortly thereafter, which would continue to move the survival mark upward and upward, and we would continue to improve the prognosis for our patients with advanced stage HCC. Unfortunately, after publication of the SHARP and the Asia Pacific trial, the next 10 years was really littered with multiple negative trials that failed to show a significant benefit over sorafenib. And so sorafenib continued to be the only systemic therapy option that we had for nearly a decade. This changed in 2018 with publication of the REFLECT trial, which once again you've heard about. This was a large phase 3 non-inferiority randomized control trial comparing lenvatinib versus sorafenib. So two tyrosine kinase inhibitors that were being compared head to head. This was a global trial, open label, non-inferiority study, which once again included patients with unresectable HCC, but otherwise had good liver function, good performance status, and adequate organ function. Notably, the REFLECT trial excluded patients with greater than 50% liver involvement, bile duct invasion, or VP4, or main portal vein invasion. These patients were not included in the REFLECT trial. And the remaining patients were randomized to receive lenvatinib at its weight-based dosing, 8 milligrams if the patient weighs less than 60 kilograms, or 12 milligrams if the patient weighs more than 60 kilograms, or sorafenib, once again, at its typical dose of 400 milligrams twice daily. The primary endpoint of the REFLECT trial was overall survival, multiple pre-specified endpoints, including progression-free survival, time to progression, objective responses, and quality of life. Now, once again, these are two tyrosine kinase inhibitors, but there are important differences between lenvatinib and sorafenib, including the receptors on which they act. Sorafenib and lenvatinib are both very active against the VEGFR pathways, but notably, lenvatinib is more active against the FGFR pathway. And you can see the IC50s on the right-hand side, once again, reflecting that lenvatinib really acts more on the FGFR pathway than we see with sorafenib. Now, moving back to the clinical trial, the primary endpoint, once again, being overall survival. And in short, what we found in the REFLECT trial is that lenvatinib had non-inferior survival compared to sorafenib. You can see the survival point estimates, 13.6 months for lenvatinib, 12.3 months for sorafenib, and the hazard ratio point estimate being 0.92. When one takes a look at the 95% confidence interval, the 95% confidence interval crosses 1, meaning lenvatinib was not superior to sorafenib, but the upper limit was within the non-inferiority margin, which was set at 1.08. So this study was powered to demonstrate that lenvatinib had non-inferior survival compared to sorafenib. This allowed us to then examine multiple secondary endpoints, once again, including progression-free survival and objective responses. Now, you've already heard that lenvatinib had significantly better progression-free survival and responses compared to sorafenib. We saw nearly a doubling of the progression-free survival with lenvatinib compared to sorafenib, 7.4 months versus 3.7 months, hazard ratio showing a 34% improvement in this progression-free survival. When we take a look at objective responses, we see nearly 3 times higher responses with lenvatinib compared to sorafenib, whether one uses the modified RECIST criteria or the traditional RECIST version 1.1. In brief, once again, modified RECIST is taking a look at the enhancing viable portion of the tumor, whereas the RECIST version 1.1 is really taking a look at the entire treatment cavity, whether enhancing or non-enhancing. And you can see, with the modified RECIST criteria, the objective response is around 12% with sorafenib and over 40% with lenvatinib. And when you take a look at the more conservative RECIST version 1.1, you see responses in around 7% of patients with sorafenib and 18 or 19% of people with lenvatinib. So once again, either way, 3 times higher responses with lenvatinib compared to sorafenib. Moving on to the adverse event profile, Overall, you've heard that the quality of life estimates were similar between lenvatinib and sorafenib. And when you take a look at the specific AEs, once again, you see the same types of AEs between the lenvatinib and sorafenib when you do the evaluation of the REFLECT trial. However, the incidence of those specific AEs does notably differ between the two agents. We see higher incidences of hypertension, anorexia and weight loss, proteinuria with lenvatinib compared to sorafenib, but we see notably higher incidence of hand-foot skin reaction with sorafenib compared to lenvatinib. And so outside of the secondary endpoints, I do think that these differences in adverse event profiles can potentially be important when you're discussing these two TKIs with your patient and choosing between the two TKIs in those patients who may not be eligible for atezolizumab and bevacizumab. Now, we've talked about that the responses are notably higher with lenvatinib versus sorafenib. And the question is, does this matter? And so this was a secondary data analysis that was done off the REFLECT trial, presented at ASCO GI now a couple of years ago, and was an analysis taking a look at those patients with response versus those patients without response and looking at their overall survival. So this was here you can see the Kaplan-Meier curves for those patients with response versus non-response. And you see the survival is significantly higher in those patients with a response. So 22 months in those patients with a response to either agent versus 11 months in those patients without a response, hazard ratio 0.61, and this was statistically significant. When you do landmark analyses, whether this was at 2 months, 4 months, or 6 months, typically corresponding to when we would perform imaging to assess response, once again, doesn't matter in terms of those response time periods. Those patients who are seen to have a response on imaging, once again, significantly improve survival compared to those patients without response. So this is important in terms of determining potentially the benefit of response, but also helpful when you're talking to your individual patient in clinic, because once again, we have the overall survival estimates as an aggregate, but when you see a patient and they have a response, this helps you once again discuss that these patients do appear to do better, and you can talk about more individual prognostic estimates for that patient with a response on either one of these agents. Now, there have been other secondary data analyses done off the REFLECT trial. Once again, this was a secondary data analysis presented at ASCO GI a couple of years ago. And this took a look at the importance of post-progression treatment. So in those patients who were found to have progression on the REFLECT trial, those patients were then allowed to be subsequently treated with other agents. We know that those patients who were treated with lenvatinib, about 1/4 of those patients were subsequently treated with sorafenib. And, in terms of patients with sorafenib who had progression, about 12% of patients continued on sorafenib. However, overall, when you take a look at any cancer medication during the follow-up period after progression, you see that there were approximately 1/3 to 40% of patients who went on to be treated with another subsequent anti-cancer treatment. This was about 32 to 33% of the lenvatinib group, compared to about 39% of the sorafenib group that then went on to receive another anti-cancer treatment. This secondary data analysis then compared those subgroups in terms of patients who were subsequently treated with another agent or not subsequently treated with another agent. And in both of those subgroups, lenvatinib was found to have non-inferior survival compared to sorafenib with hazard ratios of 0.87 and 0.90, respectively. When you take a look at the median overall survival for both of these subgroups, you can see once again on the far right-hand side of the bottom figure, you can see in those patients who went on to receive other anti-cancer treatments, a median survival 21 months versus 17 months, versus 12 months and 9 months in those patients not subsequently treated with another medication. This likely reflects, performance status or liver dysfunction at the time of progression. But once again, useful point estimates, not only in terms of comparing the two medications, but also in terms of offering individual prognostic data to your patient that you see in clinic. Now, the REFLECT trial was adjusted for, had multiple variables in terms of stratified analyses to try to keep the two arms balanced, as well as obviously the randomization. However, there were some small differences between the two groups in terms of sorafenib treated and lenvatinib treated that naturally happens in any randomized control trial. This was a post-hoc analysis that was covariate adjusted in terms of comparing the lenvatinib treated and sorafenib treated patients. You can see the authors of this study did two different models. Model 1, including covariates that were slightly imbalanced at the time of randomization, and model 2, basically also including more post-treatment variables, including the post-treatment medications and any post-treatment procedures. Whether you use model 1 or model 2, when you do this post-hoc covariate adjusted analysis, there was a signal that suggested that lenvatinib was associated with significantly improved survival compared to sorafenib, once again, with a 24% reduction in mortality, whether you use model 1 or model 2. And in these covariate adjusted models, you can see the 95% confidence interval now below 1 in terms of the upper limit, suggesting statistical significance in these post-hoc analyses. This was another interesting analysis that was presented at ASCO GI earlier this year, looking at those patients who started on the REFLECT trial as a Child-Pugh A patients, but then progressed to Child-Pugh B while on treatment. So these patients, as one would expect, taking a look first at the Kaplan-Meier curves, you can see that those patients who went on to develop Child-Pugh B disease, not surprisingly, had worse survival than Child-Pugh A patients, 7 months versus 13 months, once again highlighting that, progressing in terms of liver dysfunction is a poor prognostic sign in general. And so this is just useful, once again, when you're talking to your patient who sits in front of you in clinic. Now, moving to the bottom left-hand side of the slide, this is data that takes a look at the duration of treatment as well as the adverse event profile while on lenvatinib. And so this is comparing patients on lenvatinib who progressed to Child-Pugh B while on treatment versus those who remained a Child-Pugh A patient. Not surprisingly, the median duration of treatment shorter for those patients who went on to develop Child-Pugh B disease. You can see that the adverse events was higher in those patients with Child-Pugh B disease. In terms of any treatment-related AE, 18% versus 10%, grade 3 or higher, 3.5% versus 1.5%. And so once again, these data suggest that the AEs higher in Child-Pugh B patients. But overall, when you take a look at those patients who had dose reductions, interruptions, et cetera, you can see that the numbers all are within tolerable ranges. And so one would suggest that even though these are higher numbers, overall lenvatinib may be tolerable in these patients who have Child-Pugh B disease, and not an independent reason to remove the drug at that time. Moving on to the far right-hand side of the slide, we can start to see efficacy signals. So this takes a look at the best overall response and comparing the sorafenib arm on the far right versus the lenvatinib arm on the left. You can see when you take a look at the Child-Pugh A patients, you see the responses once again 3 times higher in the lenvatinib group among the Child-Pugh A patients. And similarly, among the Child-Pugh B patients, we do see similar comparative efficacy of 3 times higher responses in those patients with Child-Pugh B disease compared to sorafenib. Now comparing within the lenvatinib arm, we do see slightly lower responses among Child-Pugh B patients than Child-Pugh A patients, but overall small numbers, something just to consider when you're considering the risk-benefit ratio for those patients who progress to Child-Pugh B patients while on the medication. Now, I have started by focusing on the efficacy data. These data that I presented so far have all been subsequent analysis from the REFLECT trial, but this really reflects the efficacy. So, when we take a look at efficacy, this is traditionally how well this medication can work in very well-selected patient populations, in very well-selected centers. And so, this once again selected patients with Child-Pugh A disease, limited tumor burden, and once again was done in selected centers. But obviously, we need to know how well this works in clinical practice, and this is really the effectiveness of this medication when it's applied to broader patient populations and broader centers across the world. Now, one of the advantages of sorafenib is that it's been around for over a decade. And so we have a lot of real world effectiveness data, including from registries such as Gideon, that show that sorafenib is tolerable in extended patient populations. And the effectiveness signals in terms of responses and survival appear to be similar that what was observed in the SHARP trial. Now, lenvatinib has been on the market for a shorter period of time, with the REFLECT trial being published in 2018, but we now are starting to see real-world effectiveness data that are coming out globally. So some of the early real-world effectiveness data that came out from Japan. This was a retrospective cohort study from 7 institutions in Japan, taking a look at the use of lenvatinib from 2018 to 2019, 150 patients. And you can see here the characteristics of those patients. Notably, there were patients with larger tumor burden, including more than 7 lesions, size greater than 5 centimeters, main portal vein invasion, and there were about 13% of patients who had Child-Pugh B disease. The comparison of Child-Pugh A versus Child-Pugh B was one of the primary comparisons that they had here, and you can see that the adverse event profile in the far upper right-hand side of the slide. You can see that the adverse events from an individual basis, very similar between Child-Pugh A and Child-Pugh B disease, although there was higher drug discontinuation due to the adverse event profile in Child-Pugh B patients compared to Child-Pugh A patients. When you take a look at the effectiveness signals in terms of responses, progression-free survival, the authors compared Child-Pugh B to the overall cohort, as well as those with a higher burden of disease. And you see overall the responses similar in these 2 subgroups that were not included in the REFLECT trial, as well as similar progression-free survival compared to the overall cohort. Given the poor prognostic factor of Child-Pugh B disease and high burden of disease, not surprising that the overall survival signal was lower, but overall suggests that this may be tolerated in these extended patient populations. We are seeing similar real-world effectiveness data now come out from the US that takes a look at lenvatinib in a real-world effectiveness setting. Once again, extended patient populations in terms of non-hepatitis B patients, some patients with main portal vein invasion, and including some patients with more advanced liver dysfunction, 39% of patients with Child-Pugh B, 7% of patients well-selected Child-Pugh C in this real-world effectiveness study. And overall, when we take a look at the effectiveness signals, both in terms of overall survival as well as responses, we see similar responses and overall survival and progression-free survival in Child-Pugh B patients compared to Child-Pugh A patients, suggesting there may be some benefit in terms of using this in extended patient populations. Finally, we see real-world effectiveness data from Canada. This was a retrospective cohort study from 2018, 2020, including patients with more broad etiologies of liver disease, more advanced liver dysfunction, including main portal vein invasion, some patients with Child-Pugh B disease, and 20% of patients who received lenvatinib beyond the first line, so in second or third lines. Once again, important data as we start to have other first-line agents available, including atezo-bev at this time. First, you can see that the AE profile of patients that were included in this study, once again, fairly similar, although slightly higher AEs than observed in the REFLECT trial, but once again, useful in terms of the AEs observed in clinical practice. And we see continued high responses, both in the first line as well as subsequent lines, about 20% of patients in both first and second line, high proportions of disease control rate, and progression-free survival, 8 months in the first line, 5 months in the second line, suggesting that this has some effectiveness even beyond the first-line setting. Now, for the next part of my talk, I want to start to briefly address, some expanded criteria or uses for lenvatinib even beyond the advanced stage setting. So I've talked about the efficacy data for lenvatinib in the advanced stage setting. I've talked about some of the real-world effectiveness data in the advanced stage setting, and I want to now talk about some potential expanded uses, including patients with larger intermediate stage or BCLC B stage disease. There's been increasing recognition that there's heterogeneous prognosis after chemoembolization. Here you can see one of the prognostic scores that was developed and validated, the 6 and 12 score. So when you add up the sum of the diameters plus the number of tumors, you can get a score that can range anywhere from 2 or 1 to up to well beyond 12. And those patients whose sum of the diameters plus tumor number that exceeds 12, we see these patients have notably worse prognosis after chemoembolization than those patients with more limited tumor burden. And so this, raises the question of, if these patients would benefit from alternative therapies besides local regional therapies. We know that these patients with larger tumor burden often require repeated local regional therapies, and repeated local regional therapies or chemoembolizations can lead to decline in liver dysfunction. And so in the Optimus trial, which was a real-world trial looking at TACE receipt, there were 1 in 4 or 25% of patients who had decline in liver function from a Child-Pugh A status to Child-Pugh B or C status at the time of TACE ineligibility. And so this suggests that these patients with larger tumor burden, by performing chemoembolization, you may have significant decline in liver dysfunction, which precludes the receipt of systemic therapies. There are some now data suggesting that lenvatinib or other systemic therapies may be beneficial in these patients. This was an abstract presented at ASCO last year, retrospective multi-site Japanese study, 88 patients with intermediate stage disease who were treated with lenvatinib, the vast majority being beyond up to 7, 95% received lenvatinib in the first line. And you can see here objective responses nearly 50%, disease control rate over 75%, progression-free survival 8.7 months, and the median survival was not reached during this median follow-up. So these data are early, but do suggest potentially lenvatinib or other systemic therapies may be considered in these patients with larger intermediate stage disease. This was another interesting analysis by Kudo and colleagues published a couple of years ago. This took a look, it was a propensity-weighted analysis comparing patients with intermediate stage disease with larger tumor burden who were treated with lenvatinib and compared to patients treated with chemoembolization. Overall, 90 patients in the study. And what we can see here in this propensity weighted analysis is those patients treated with chemoembolization in the first line actually had significantly better survival compared to those patients who received chemoembolization up front. Not shown on this slide is a second analysis that took a look at the LB scores during follow-up. And really one of the drivers of this difference in survival is worsening LB score in those patients who had received chemoembolization up front compared to those patients who had received systemic therapy up front. So once again, suggesting that lenvatinib may be considered as an upfront line therapy in these patients with larger tumor burden in the intermediate stage. And so actually the Asia Pacific expert consensus statement defines criteria for patients who are TACE unsuitable, i.e. patients who should be considered for frontline systemic therapy. And so these conditions include the ones listed in this table, but include patients that can easily become refractory to chemoembolization or who are at higher risk of liver dysfunction with chemoembolization. And this includes notably patients with tumor burden beyond up to 7 criteria or patients with LB grade 2 at baseline. So once again, considering systemic therapy earlier, if not upfront in these patients with these criteria. Now, for the last couple slides here in terms of the data, I've really focused so far on lenvatinib single agent, both in terms of the effectiveness of this in the advanced stage setting, as well as potentially using this in some patients with intermediate stage disease. But of course, we are aware of the exciting data coming out with immune checkpoint inhibitors, as well as combination therapies. And there's also data now combining lenvatinib with pembrolizumab, and this may be how lenvatinib is really used as we move forward. So there's phase 1b data looking at the combination of lenvatinib and pembrolizumab in advanced stage HCC. Just over 100 patients who received this. This was a single arm study in terms of the phase 1b/2a study. And in what we can see here, when you take a look at modified RECIST, you can see high efficacy, 46% of patients having a response here. And when you take a look at the median overall survival, you see a median OS of 22 months. So it crosses this 20-month barrier in terms of having an OS signal. So very exciting in terms of the phase 1b data. And overall, when you take a look at the grade 3 treatment-related AEs, was deemed to be a tolerable combination with no unexpected AEs. So of course, this is early data. This is single arm phase 1b data. And so we do need to see if these efficacy signals in terms of the point estimates continue to be observed in the phase 3 data. This is the LEAP-002 trial comparing the combination of lenvatinib and pembrolizumab to single agent lenvatinib in the advanced stage setting. So this trial primary endpoints being overall survival and progression-free survival. And essentially, we're just waiting for this trial to report out in terms of finding out, if this efficacy signal and safety signal is continued in the phase 3 trial. So for the last few minutes of my presentation, I'd like to end with a couple patient cases to really highlight how we can apply these data to our patients that once again present to us in clinic. So the first patient case that I have is a 67-year-old male, Hep C cirrhosis, presents with abdominal pain 5 years after a sustained virological response. The CT imaging in the emergency department demonstrates a large liver mass. This really goes back to where we first started in terms of this presentation. You heard from the very beginning that the sustained virologic response is critical in these patients with a history of hepatitis C, notably reduces the risk of HCC, but unfortunately does not eliminate it. And so surveillance like that's being done in Egypt is critical in these patients. And this case unfortunately highlights what happens if you do not perform surveillance in these patients with sustained virologic response. These patients often then, in the absence of surveillance, present symptomatically with advanced tumor burden. This patient had an MRI subsequently that showed a large liver mass, shows arterial enhancement, delayed washout, and he unfortunately has vascular invasion. Further, has a chest CT that's done that shows pulmonary metastases. And you can see the good news is that because he had the DAA treatment, his liver function, he remains compensated, no ascites, no encephalopathy, and the liver function remains great. His bilirubin's 0.9, albumin 3.7, INR 1.1, and his platelet count 107,000, suggesting minimal portal hypertension. So what would be the recommended management strategy for this patient? Should we basically say, that he has undergone DAA treatment, he's post-SVR 5 years out, highly unlikely to be HCC? Do we need to biopsy this lesion? Should we refer for local regional therapy, perform an EGD to assess for varices, start atezo and bev, or start lenvatinib? So here you can see the actual imaging with the tumor delineated nicely on the MRI. You can see both the enhancement and the washout, once again suggesting a large liver mass as well as vascular invasion. So for this patient, once again, now that we see that he has HCC with vascular invasion, distant metastases, the question is, what do we do next? And the correct answer in this case is to perform an upper endoscopy to assess for varices. And so It's important to note that even though he has good liver function, minimal portal hypertension, all of these patients should undergo an upper endoscopy to assess for varices. And here you can see the results of his upper endoscopy, once again showing the presence of fairly large varices in this patient. And this is important that because even if somebody is a Child-Pugh A with minimal portal hypertension, varices can be present in about 40% of patients with Child-Pugh A disease. And this continues to increase as somebody develops more notable portal hypertension. And the presence of varices actually increases up to 75% if people have decompensated disease, Child-Pugh B or Child-Pugh C. So do not get fooled just because somebody has good liver function when they present that you don't need to do the upper endoscopy. This is critical. And really the safety of atezo-bev is because of this patient selection in terms of assessing for varices and not putting somebody on if they have high-risk stigmata and or treating the varices prior to starting atezo-bev. But in these patients with high-risk varices, other agents should be considered upfront. And so this patient with Child-Pugh A disease, vascular invasion, distant metastases with larger varices, it would be very reasonable to start TKI therapy upfront with either sorafenib or lenvatinib. And once again, going to the beginning of the presentation, this is somebody where we should discuss the differences between sorafenib and lenvatinib, both in terms of responses, as well as in terms of the differences in terms of AE profile between the two TKI options. So second patient case, 49-year-old male, NASH cirrhosis, Child-Pugh A, no portal hypertension, presents with bilobar multifocal disease. This patient underwent an upper endoscopy, had no significant varices at that time, was treated with atezo and bev, had initially stable disease, but unfortunately after 6 months was noted to have disease progression. Fortunately, this patient has compensated liver disease at the time of progression, bilirubin 1.1, albumin 4.2, INR 0.9. The patient is great, continues to actively work, has a good performance status. AFP is elevated at 497. So, I think the patient unfortunately is disappointed by his lack of response. I think coming in, this was one of the big things that was discussed with the patient was, the 30% response that you can have with atezo-bev. And he really thought that he would be within this 30%. And so, when he had progression, he was like, I really want to go on the therapy that would optimize my chance at response at this time. So now thinking through after progression on atezo-bev, understanding we're in a little bit of a data-free zone, what option would we consider in this patient who, once again, main priority is the highest response possible? Here you can see all of the different treatment options, some of them that we talked about in this talk and some that you heard were available in the second line setting in the prior talk, but multiple targeted agents. Of course, we also have Nivo and Pembro that can be used in the second line setting. Or do we just call it a day and say this patient is not eligible for any second line treatment? And really, I would argue that the best treatment for this patient in the second line setting for this specific desire is to start lenvatinib. We know that lenvatinib has the highest responses among all of the different options here. Many of us, after atezo-bev, use a strategy of going to TKI therapies. And even though we're in a data-free zone, I think many of us go to like what we would regard as a T-1 approach, considering sorafenib or lenvatinib as the preferred agents in the second line setting, and then moving currently available second line therapies into the third line. And so at least my personal view is after atezo-bev, I would use either sorafenib or lenvatinib. And then after that, I would use either regorafenib or cabozantinib in the third line. One can argue that cabozantinib has data in the third line, and so there may be some benefit of cabozantinib if going on to third line therapies. I think if somebody uses sorafenib in the second line setting, one can make a case for regorafenib given the sorafenib-regorafenib sequence. But I would argue that other agents like ramucirumab, nivolumab, pembrolizumab all less likely to be beneficial after atezo-bev, given the fact that you've already acted on the single agent PD-1, PD-L1 axis, as well as acted on the VEGF receptor pathway. And so these more targeted agents that act on a single pathway may be less beneficial, after using atezo-bev in the frontline setting. Another possibility beyond the TKIs is to consider the combination of Nivo and Ipi, adding in the CTLA-4 axis if one progresses on atezo-bev. But I think the majority of patients in my practice who we consider agents after atezo-bev, we would typically go to sorafenib or lenvatinib in the second line setting. So in summary, lenvatinib provides non-inferior survival compared to sorafenib, but has significantly better improvements in multiple secondary endpoints, including progression-free survival and objective responses. I presented several post-hoc covariate adjusted analyses, including differences in the post-progression treatment that suggested further improvement in survival with lenvatinib compared to sorafenib after adjusting for small differences between the two arms. We know that sorafenib has extensive real-world data, given the fact that it's been available for over a decade now. We are seeing increasing real-world data demonstrating tolerability as well as effectiveness, both in real-world patient populations included in the REFLECT trial, as well as extended patient populations not included in the REFLECT trial. Systemic therapy, including lenvatinib, may be considered in select patients with large BCLC stage B disease who are unlikely to benefit from chemoembolization, may be at higher risk for liver dysfunction, and may be regarded as actually taste unsuitable from the very beginning. And finally, lenvatinib is currently being evaluated in combination with pembrolizumab in a large phase 3 randomized control trial, and we do expect data from LEAP-002 to be available soon. And if this is positive as one expects, this would be another frontline option that one would have to weigh against atezo-bev as a frontline option for your patients with advanced stage HCC. With that, I'd like to thank once again the organizers for inviting me here, and I'm happy to take any questions as part of the discussion.
Thank you, Professor Signal and Dr. Iman, for the very informative session about the systemic therapy. And now I'd like to invite Professor Iman to provide us a final conclusion about how to go from the data that we have received from the clinical trials about the systemic therapy and their role in the management of advanced HCC to our clinics and to our real-life practice in the hepatology clinics in Egypt. So please, Dr. Iman, we need your comment about this.
Sure. As you see, a lot of treatments are available, and this was the last part of my talk. And I see that the treatment should be tailored for every patient, not to take it like this globally, and the need for the presence of biomarkers to decide which treatment to be chosen for each patient is coming, and this necessitated to be present, and agreed with Professor Amir that we may extend the use of the systemic therapy together with other modalities like TACE, not only replacing TACE, but using these modalities as an adjuvant with the other modalities for treatment of bacterial carcinoma. I think it will give us a better results, and use these drugs again in the downstaging of bacterial carcinoma to make the patient amenable for the curative treatment, transplantation.
Okay, thank you, Dr. Iman. This was very elegant presentation. And I think now we have to move to the second part of our session today.
We are a little bit in short of time, but we have a very quick question for Professor Singhal. Can we elaborate more on the point that you have mentioned in the first case about proper assessment of the patient? For instance, you mentioned using EGD to check for portal hypertension. So some people rush into treatment without assessing the patient properly, and this will increase the risk of therapy interruption. At the same time, it will increase the risk of decompensation. Can you talk about this a little bit more?
Yeah. So, as part of the IMBRAVE 150 study, everyone was required to undergo an upper endoscopy within 6 months of starting or being randomized to atezo-bev versus sorafenib. And when we take a look at the AE profile and the tolerability of atezo-bev, it largely goes to that selection criteria. And so, patients with high-risk stigmata, large varices, significant portal hypertension with a platelet count less than 75,000 were all excluded from the IMBRAVE 150 study. And so, when you take a look once again in terms of the efficacy or the safety observed in that trial, it really is with that careful patient selection in mind. We know that BEV significantly increases the risk of bleeding and can do so particularly in patients if they have underlying stigmata already. And so by skipping this step of an upper endoscopy, you may be once again increasing the risk of bleeding by going on to atezo-bev without doing this careful assessment. And we know that if somebody has upper GI bleeding first, that can be life-threatening. So we know that 5 to 10% of people can die from an upper GI bleed, even despite advances in our management of upper GI bleeding. And the second is that even if you survive the upper GI bleed, there are a portion of people who then have liver dysfunction. They go from a Child-Pugh A to a Child-Pugh B after that upper GI bleed, and therefore, once again, may not be eligible for further systemic therapy. So you may be actually harming your patient by rushing into systemic therapy instead of doing the upper endoscopy upfront. So I can tell you, we are very, we believe that's a critical step, and we perform the upper endoscopy prior to considering atezo-bev in any one of our patients. Now, one other thing that I'd say is, as you have somebody in the intermediate stage setting, one of the things you can do is do the upper endoscopy earlier. So don't wait until you need to go on to systemic therapy, but prepare your patient in advance. So even if they're in the local regional setting, if you do the upper endoscopy and they have progression, then you've done that step and you're ready to start systemic therapy faster. So there's things that you can do, but I don't think it's a good idea to skip this. The last thing that I'd say is when you do, there is a post-hoc analysis of the IMBRAVE 150 study. This is most important in those patients with portal vein invasion. We know that portal vein invasion increases portal hypertension, increases the risk of varices, increases the risk of variceal hemorrhage. And so if you have a patient, all patients should have this done, but particularly for anyone with portal vein invasion, that one should consider that patient is the highest risk for variceal hemorrhage and bleeding.
Thank you so much. Thank you so much. So I think now we're going to shift to some clinical cases with Professor Ashraf Al-Beredi, Professor of Tropical Medicine, Ain Shams University, and Professor Tamer Al-Baz, Professor of Endemic Medicine, Cairo University. Stay with us, please.
Okay. Bismillah ar-Rahman ar-Rahim. First, I'd like to thank the IFID organizing committee for inviting me to this fruitful meeting. Actually, I didn't know that Professor Sengal has cases in his presentation, and actually he answered most of the questions in the case, but I'll try to have also my questions. In this case presentation for a male patient, Egyptian patient, 52 years old, with no diabetes or hypertension. He is known to have liver cirrhosis due to chronic hepatitis C virus infection and achieved sustained virologic response after direct antiviral agents since 4 years, but he didn't follow any surveillance program. There was hepatosplenomegaly on examination. He discovered hepatic focal lesion by ultrasound due to persistent abdominal pain. This is a laboratory investigation of the patient, LT64, AST 55, albumin 3.5, INR 1.3, bilirubin 1.8. His hepatitis C virus PCR negative and surface antigen was negative, sorry, it's not positive. Alpha-fetoprotein was 1,400. Actually, this patient performed upper endoscopy before, after discovery of this. He had 3 columns of severe varices, grade 1 to 2, with the Ritzky signs, and endoscopic variceal ligation was done. His tribasic CT shows the multicentric HCC with right branch portal vein thrombosis. So this is a patient summary: child class A, child score 6, mild score 13, performance status 1, BCLC stage C, and alpha fetoprotein 1,400. And according to BCLC staging system, we can see this patient, straightforward patient, is in BCLC stage C, and the systemic service will be offered, as you said before. And this is according to the to ESMO guidelines 2020. The first line therapy either Terafenib or Lenvatinib or Atezo and plus Beva as a first line treatment. My questions, and you answered some of them. Which treatment would be of the right choice? What about safety of using Lenvatinib with patients with portal hypertension and varices? And if Lenvatinib fails to show response, should we go for the second line used after sorafenib as regorafenib or cabozantinib? And as I said that you answered most of these questions, I have a additional question. What about combining TACE and Lenvatinib? As you know that there were several studies about combining sorafenib with TACE. Most of them showed disappointing results, except one or two. Is there any studies about combining TACE with Lenvatinib? And what about your ideas or what you're thinking about this combination? Thank you.
Yeah. So I guess from my perspective, I think that you're right that there's been multiple trials that have looked at the combination of TKIs in combination with chemoembolization. And although, for example, the TACTICS trial suggested, some improvement, the majority of these trials, the TACE2 trials, SPACE, et cetera, understanding most of them use sorafenib, failed to show a benefit of using the two in combination versus chemoembolization alone. And, when we take a look at this, you have to consider not only the potential benefit in terms of responses and PFS and OS, but also the potential for AEs. And so, there's really a risk-benefit ratio. There are less data with the combination of Lenvatinib and chemoembolization, although I do believe there's, some early data that once again showed some potential benefit of using the two in combination. Although our clinical practice is not to combine the two, short of any larger studies demonstrating a benefit of using the two in combination. We typically, at this point, use one or the other. We heard already about the reference to some of the ongoing trials of also using IOs in combination, the immune checkpoint inhibitors with, chemoembolization or radioembolization or other local regional therapies. Those trials are also early in terms of their evaluation, but at least in my opinion, there's probably more interest in that combination moving forward rather than the TKIs plus local regional therapy. So right now we use one or the other while awaiting more trial data. We don't typically use the two in combination.
And I want to know, after banding of these viruses, is there any time to use Lenvatinib in such patients, or I can go for use it once I ban these patients?
Yeah, so for those patients with larger varices, or history of bleeding, et cetera, particularly for those patients who require banding, I think Lenvatinib is actually a very reasonable choice. Because banding is not just a one-time thing. When you start banding, you typically have to band multiple times to really have sufficient eradication of those varices. So it's not like you would take that patient to an upper endoscopy, do the banding, and you can start Atezo-Bev 2 weeks later. You typically are talking about, potentially delaying therapy for a period of, a couple months, if not sometimes longer. Sometimes we see very difficult to eradicate varices. So I think that Lenvatinib would be a very good choice up front for those patients, once again, working on the varices. And then, if that patient has progression on Lenvatinib, you could also then consider using Atezo-Bev after that. But I think that for those patients that have sufficiently large varices or sufficiently worrisome stigmata, I think going on to TKI therapy up front makes sense.
Thank you very much. About last question, if Lenvatinib fails to show any response, should we use second line as used in after sorafenib?
Yeah, so if somebody is on Lenvatinib, what do you use after progression? I think that it's much like the atezo-bev, where you're applying the data after sorafenib to other agents. And so, our typical strategy after failure of Lenvatinib is to consider, other second-line therapies just as you would after sorafenib. Once again, whether that be single-agent PD-1 inhibitors, that are at least have accelerated approval, Nivo or Pembro, or other TKI-based therapies such as regorafenib or cabozantinib. I think those are, oftentimes we'll use one of those agents after Lenvatinib failure.
Okay, thank you. Thank you for your answers.
Bismillah ar-Rahman ar-Rahim. Of course, it's my pleasure and an honor to share today the USHID third wave session for hepatocellular carcinoma. I am Professor Tamer Elbaz from Endemic Hepatology and Gastroenterology, Cairo University, and I am a co-founder for the Qasr Al-Aini HCC multidisciplinary team since 2009. I'm going to present today a successful story of management of a patient with advanced HCC. And actually, we were happy while managing that patient because in clinical practice, majority of patients coming for hepatocellular carcinoma clinic do suffer from advanced liver disease at the same time with advanced HCC, and that causes a problem. So we were happy while managing that gentleman. He is a male patient, 64 years old. He accidentally discovered the presence of a large HCC in November 2018, and the patient presented to us for further evaluation. So from his labs, we can notice that he has thrombocytopenia, and he was a child score A6 because of albumin that was 3.1, and his alpha-fetoprotein exceeded 1,000. Still, his performance status was 1. When he performed the diffusion MRI, we can notice first the presence of well-circumscribed lesion measuring 5 centimeters that was present in segment 4 of the liver. Moreover, you can notice that the right lobe, the posterior division, is infiltrated with a large mass. That mass is affecting even the inferior vena cava, and it led to almost complete thrombosis apart from a rim. And further, you can notice that the portal vein, the right portal vein, is also thrombosed. So we do have a large mass and another one well-circumscribed mass. We do have inferior vena cava thrombosis and right portal vein thrombosis. By MRI diffusion, you can notice the tumor load and tumor burden that was present at that same time. So according to the modified BCLC staging, we are at the advanced stage C due to presence of portal vein invasion with still preserved liver function and performance status 1. So we proceeded our decision after discussion in multidisciplinary team. We do have hepatologists, interventional radiologists, hepatobiliary surgeons, and oncologists. So we reached a decision to perform transarterial chemoembolization using drug-eluting beads to avoid ischemia and performing and using immunotherapy. So why to proceed first with the local regional therapy and with TACE? There is a rationale that there is a favorable immune modulation effects of the local regional therapy, and this can promote the efficacy of the immunotherapy through different mechanisms. The 3 main actions that we can gain from proceeding with TACE before proceeding with immunotherapy, it's a facilitating the release of tumor-associated antigens, such like the heat shock protein 70, the change of the level of cytokine expression, and the increase in the level of interferon gamma, tumor necrosis factor, interleukin 1 and 2, while decreasing the level of interleukin 10. And the third action is the promotion of the immune function of the lymphocytes. So he proceeded first with TACE. You can notice here first the presence of that lesion, the first one we described that present in the segment 4, the well circumscribed, and it was ablated like this. and the large infiltrative mass with a large tumor burden and arteriovenous shunting, arterioportal shunting. The patient following use of TACE, after the session of TACE, by 3 weeks, he started cycles of nivolumab as an immunotherapy. That was in November 2018, and we can notice in March 2019, during the follow-up, the mass that was present here is almost completely ablated. And concerning the large infiltrative mass, you can notice that the tumor burden much decreased, and even the inferior vena cava opened by 50% after cycles of nivolumab. Then he continued treatment, and we found no enhancement at the right hepatic lobe. It looks like as if we did a hepatectomy. It shrunk in size, and the tumor burden decreased so much. Again, he continued nivolumab for 3 months more, and in December, for 3 months more, yes, and then he stopped in June 2019, and he continued just on follow-up. That was in December 2019, still no enhancement, right hepatic lobe atrophy, and further retraction of the AVC and the right portal vein thrombosis. You can notice from the images that the lesions that was present in segment 4 is no more present. The inferior vena cava opened, and the mass, the right mass, it looks like disappeared with the liver itself. Again, for the MRI diffusion, you can compare between the before starting the TACE and taking nivolumab, and post, that lesion almost disappeared. The patient is following up with us. Performance status is 0 now, and he completed up till now 30 months of survival and follow-up, and he's in a good condition and still on follow-up while he stopped the nivolumab since, as we said, in June 2019. That pictures again are the before starting treatment, and you can compare with 13 months after what happened thereafter. Even alpha-fetoprotein normalized. It was before treatment 1070, and it normalized during the follow-up. And thank you very much.
Thank you, Professor Tamer and Professor Ashraf, for the very elegant presentations and case discussions. And I think now, Dr. Negm, we have to move to the last part of our session today, to the questions and answers. So I'm inviting you to start with the question that you have.
Yes, I'm inviting all our speakers to join us, please. Professor Gamal, Dr. Iman, Professor Iman, sorry, and Professor Singal, please be with us. Also, Professor Ashraf and Professor Elbaz stay with us too.
So, can I start with a question?
Yes, please, definitely.
Yeah,
yes.
Okay. So, actually, I do have 2 questions, Professor Singal. The first one, in such a successful story while managing an advanced HCC, and you succeeded, as we have seen, for almost complete ablation, and maybe it's full ablation. When am I justified to proceed for liver transplantation? Because that's a too tricky question. Usually they are asking for long follow-up for visualizing the tumor behavior, but for how long? When can I take a decision that the patient can shift for liver transplantation? Because almost all of our centers are refusing the idea of performing liver transplantation even with such a successful story. That's the first question. And my second question, usually in studies talking about the second line therapy, they do not differ between if they are using a second line because the first line was stopped due to primary non-response, or it was stopped due to drug discontinuation. I think there's a big difference between both of them. A patient who stopped due to drug discontinuation still is responding, and maybe he will have a better chance, while the one who's primary non-response, I think his chance for treatment, even with a second dose, will be lower than the one. Thank you very much.
Yeah, no, those are 2 excellent questions. And so I'll tackle the first one first. And so I guess I'm glad you showed that case, because I think it, it really does highlight how, the exciting times that we're in. I think, we can all sort of appreciate the fact that if that patient had presented 5 years ago, we would have had a very different discussion around this case.
Yes.
And I don't think we'd be showing it here. I think we'd be sort of like just hiding it, like in the type of thing where, so I think it's an exciting time in the management of HCC. And so I'm really glad that you showed that, because it really does highlight that this is not a death sentence anymore, that we do see these amazing responses where you took somebody who had incredible tumor burden and you gave them, a complete response. And the fact that we're even talking about if and when it's okay to do liver transplantation is, I think, the biggest amazing thing that we can see in the field. I have to say, I don't think any of us have the answer of when is it safe to do a liver transplant. Our practice is to consider this after 1 year of stability. And that is a fairly, I would say, random time frame, but it's long enough that if that patient, we know that the patient had good tumor biology. The question is that tumor biology was determined on immunotherapy, and post liver transplant, you're almost going the opposite way. You're immunosuppressing somebody, albeit with fairly mild immunosuppression after a liver transplant. And so our typical practice is to say that patient has to be downstaged. We would even take a drug holiday where you would take the patient off of IOs and continue to see response on imaging, and then to consider this. It would be on a very case-by-case basis. Yes. We have, one case that we're considering that is exactly that. He was on immunotherapy. He had a metastatic lymph node and was started on atezo-bev. The lymph node basically disappeared. His AFP came down from thousands down to 5. And he's now had that response for just about 1 year. Yes. And so now we're considering, putting him on our list. And we would require him to he's been off of atezo-bev now for 2 months. AFP has remained normal. That lymph node has remained the exact same size. Yeah. As you know, the difficulty here is, where do you see complete response versus lack of macroscopic disease? But there's still microscopic disease that after transplant would, lead to recurrence. Once again, I don't think we know the answers to this. It's going to be a little bit of, we're going to do this as a community, and we're going to see what works and what doesn't work. But that's where we're starting in our center, is 1 year. The second point is extremely insightful as well, and is a great question, and brings up the question of why is that not typically a stratification variable and a subgroup analysis that's done for many of these second-line trials. There are data that have come out of the Barcelona group, not only showing any progression, but even the type of progression is important, right? Growth of the lesion versus new intrahepatic disease versus new extrahepatic disease. We even know those are prognostic. And then further, you're adding in, I agree, that if somebody has a complete response, but has an AE that requires them to come off, that patient's tumor biology is completely different. And one would expect a different response in the second line if that patient can tolerate that medication. So I don't know if I have the answer of why don't we do this, but I agree with you, and I would second your call that we should start doing that and start looking at those subgroup analyses, if not even stratified into those trials.
Yeah, true.
Okay, I do have a question, and actually it's for both Professor Singhal and Professor Iman. One of the audience is asking, do you think that the etiology of liver disease can affect your choice regarding whether to start with sorafenib or lenvatinib or things like that?
Yeah. Professor Iman, do you want to go? I feel like I've talked a lot, so do you want to talk first, and then I can add on if there's any.
I think, yes, I can talk. Okay. I think the underlying etiology should be considered in drug choice, and in some study that showed that some patient better treated with lenvatinib is better the response was better in the hepatitis B patient more than that hepatitis C patient. But I see more studies are needed. To answer this question, we have to study it more and more to be sure that which is suitable for each patient. And as I said, I think the individualization of the treatment, not even upon the etiology, but even for every single patient.
I agree with Professor Aman that we definitely need to go towards a more intelligent and personalized approach to our treatment algorithms. There's a clear need for biomarkers or clinical risk models in terms of determining what is the best therapy for any individual patient in front of us. We need to move away from one therapy for all patients.
Yeah.
Of course, this is a very tall task. There have been a lot of biomarker studies that have been done, and unfortunately, we don't have anything right now. But it's a nice continued vision for where we want to be. In terms of the specific question about etiology and how this impacts treatment decisions, I also agree that we need more data. There are some interesting signals here and there, but I don't think that currently I use etiology as a reason to choose one treatment over another in my clinical practice. Some of the interesting signals that we're seeing is, I think many of us have seen some of the data showing that immunotherapy or immune checkpoint inhibitors may have less of a response in patients with non-viral etiologies, particularly fatty liver disease. When you take a look at the subgroup analyses for non-viral versus viral, you start to see less of a benefit for immune checkpoint inhibitors in patients with non-viral liver disease. Although I think we have a lot more work to do before we say that can be used in clinical practice to determine to use or not use immune checkpoint inhibitors. The other things that we've seen for sorafenib, we've seen higher efficacy in hepatitis C patients compared to non-hepatitis C patients.
Yes,
and then, Professor Aman already brought up the hepatitis B differences in terms of lenvatinib. That being said, with all of that being said, when you take a look at the REFLECT subgroup analyses comparing lenvatinib versus sorafenib, lenvatinib's sort of comparative effectiveness compared to sorafenib was consistent across all subgroups. So, despite hepatitis C, hepatitis B, et cetera, lenvatinib was shown to have non-inferior survival and better progression-free survival in all the different subgroups of etiology. And that's why I don't use etiology as a way to choose lenvatinib versus sorafenib. And then likewise, I don't necessarily use etiology for immune checkpoint inhibitors versus TKI therapies.
Yes, I totally agree.
So I have another question from the floor also, an intersecting question with this one. They are asking about, if we are not talking about the etiology, so what are the other factors from at the time being that you are depending upon when you are selecting the tyrosine kinase inhibitors, whether to use sorafenib or lenvatinib?
Yeah. Go ahead, Professor Mann.
Go ahead first.
Okay, it's your turn. So you go first this time.
Me?
Yeah.
Okay. Yeah. Okay. So for me, what I typically do use in terms of, obviously we've talked about atezobev having our phase 3 study comparing sorafenib versus atezobev. So my first thing is, can I use atezobev in a patient? And we've already talked about the selection, particularly around the upper endoscopy, the high-risk stigmata, bleeding, its varices, et cetera. And then, of course, if somebody's a Child-Pugh B patient, I don't use atezobev up front because we have no, data for atezobev beyond the Child-Pugh A setting. Now, when we're choosing between sorafenib and lenvatinib, I think the biggest thing that I use currently in the lack of biomarkers is discussing, the differences in adverse event profile. So we talked about lenvatinib having higher anorexia, weight loss, having higher hypertension, proteinuria, and sorafenib having higher hand-foot skin reaction. So I discussed those differences in the AE profile with my patient. But then I also talk about the differences in the secondary endpoints. So like the responses and the progression-free survival, I do discuss this. And I do think that some patients will opt for lenvatinib, even though they have non-inferior survival, they will want to see a response. And it's a reason for them to stay on medication. And we did talk about those patients who have a response. It helps them stay on therapy because we know that those patients had a better survival. So I discuss those those factors with my patient, but there's nothing that makes me universally lean between one TKI versus the other in the frontline setting. Professor Aman, anything else?
Yes, I totally agree with the Professor Sengal. Sorry. The clinical baseline of the patient will lead us to whether the patient is susceptible for horrible bleeding or not, whether the patient having hypertension or responding not or refractory. This is one point. Another point in our country, the cost.
Definitely, yes.
The cost may prevent me from taking a drug from other. Another, for the patient, my Egyptian, the patient, the oral drug is usually easier than the intravenous trachees or parenteral trachees.
That's true. That's true. Okay, like let's go back to like complications and like AEs and stuff like that. If you have started a patient on any of the tyrosine kinase inhibitors and he was like child A or child B, and then he became child C, how would you deal with this? Would you like send him directly to transplantation if he was eligible for it, or would you try to shift? Would you try to like stabilize his condition or not? Can you give me some insights about that?
Yeah, I can say. Oh, go ahead, Professor Rahman.
For me, the patient is eligible for transplantation from the start. Why don't you send him from the start? Why you wait until the patient have child C and send him? That's the first part. The patient already progressed on the treatment and not suitable for transplantation. From my point of view, just let the patient in peace until clinical sophisticated studies to be done on this patient, because I do think it should be very selective.
Yeah.
I can say it in general, just if the patient progressed, you can try that, and that. No, it should be very selective for a unique patient, like the case that mentioned.
Yes.
Case was done for a patient with portal vein invasion and for inferior vena cava. This is selected for this patient.
Yes.
You can make it generalized for the other patients. Professor Singh?
You know, I completely agree. I would argue, like you did, I would argue liver transplantation and systemic therapy are two different patients. So liver transplantation is for patients with early stage disease, and systemic therapies are typically patients with larger, either larger intrahepatic tumor burden or a systemic disease or advanced stage disease. So typically, patients aren't eligible for systemic therapy and liver transplantation, so they're not competing or complementary therapies traditionally. So if somebody is transplant eligible, that should be the primary route, and you would typically bridge them with local regional therapies, and then transplant them, when possible. For those patients who are treated on systemic therapy who have, decline in their liver function, if you go from a Child-Pugh A to a Child-Pugh B, there are now studies coming out that show that those patients continue to have potential benefit. Those patients generally do okay, and have reasonable responses, et cetera. So I think it's okay if you go from a Child-Pugh A to a Child-Pugh B in some cases. I think once you progress to a Child-Pugh C, your typical prognosis is not driven by tumor control or tumor responses. It's driven by liver dysfunction. Yes. And so if somebody declines to a Child-Pugh C status, that's typically when I'll start to discuss best supportive care, hospice type management, and focus on control of symptoms from a Child-Pugh C perspective and making them have the best quality of life.
But
and then, going back to the cost.
Try once more.
Yeah, and then going back to the cost perspective, I mean, then what you're doing is essentially having high out-of-pocket costs for very little benefit. And so you may be actually financially harming the patient.
Okay, one more thing that we haven't tackled. I'm sorry?
No, go ahead.
Okay, one more thing that we have a question from the audience, a part that we haven't really tackled, which is third line therapies. Can you talk about it for a little bit? How would you choose a third line if you have tried Lenvatinib as a first line? So how would you choose?
Yeah, the only therapy that really has any data in the third line setting is cabozantinib, and so it traditionally is one that we do use if you get to the third line, understanding right now, very few patients get to a third line setting. But for those patients that, there will be times where you do this. And so that would be our preferred agent in the third line. If you've already used cabozantinib in the second line, you're essentially in a data-free zone. Nobody's going to fault you for choosing any of the other agents. So if somebody's eligible, I would not. The one thing I would not do is say, oh, I've already used cabozantinib. I don't have anything else proven in the third line, so I'm just going to not use anything. I think you can use any of the TKIs in the third line setting if somebody gets there.
Would you combine like two agents together in this setting?
I personally would not.
Professor Iman, would you do this?
Just a try.
Yeah.
Right. You are trying. We need to have a solid base for that.
There's no enough data for this, yes.
Cabozantinib premium have been suggested by the ISMO to be a third line of treatment. To use one of them or to use a combined treatment for treatment of the patient or better survival, I do think this is a matter of studies.
Yes.
Outcome studies.
Can I have another question?
I think Dr. Ashraf had a question. Sorry, Dr. Tamer.
Sure.
Yes. So,
for patients who are undergoing radiofrequency ablation, we have a significant number of patients are having recurrence and multiple recurrence. Although these recurrences within the limit of radiofrequency ablation, but we are sure that there is an aplastic process at the cellular and numerical level. Do you think that those patients with distant recurrence after radiofrequency ablation should benefit from systemic therapies?
You mean local or distant, Ashley? Local or distant?
What? I can't hear you.
Recurrence. You mean outside the liver or inside the liver?
Inside the liver, intrahepatic metastasis, intrahepatic recurrence, intrahepatic. Those patients who are having intrahepatic distant recurrence after successful radiofrequency ablation. Those patients, we encountered them in the clinical practice actually. Do you think that using systemic therapies in those patients with recurrent intrahepatic recurrence should benefit from systemic therapy, as we can combine them with radiofrequency? As you know, that radiofrequency ablation is one of the potential curative treatment options. Or what do you think? I want to hear from you your insights.
If the patient is a candidate for transplantation, I would transplant this patient. This is for first. If the patient is not a candidate for transplantation, why not use the immunotherapy or the TKIs to help this patient to stay in a free period. And after then, I will evaluate the patient for transplant.
Yes, if the patient is not ready for transplantation, and we have a lot of patients like this, so you recommend that those patients will benefit definitely from radiofrequency ablation and other systemic therapies. Like our patients, most of our patients are still waiting or can't find any donor or due to financial issues or socioeconomic issues.
Actually, evidence for some of those patients, and they should improve actually. Yes.
Yeah, I agree with Professor Iman that obviously our frontline approach would be transplantation if possible, but I mean in these patients who are not transplant eligible, understanding this represents or can represent a large number of patients. We would it would depend on the burden of intrahepatic disease. If it's more limited intrahepatic disease, we would continue to use local regional therapies, whether that's repeat ablation or chemoembolization. But if it's more bilobar multifocal intrahepatic recurrence, much like I was saying in terms of the larger tumor burden, particularly if it's beyond up to 7, et cetera, then I think that systemic therapy would be a very reasonable option in that patient. But if it's small intrahepatic, even distant recurrence, we would prefer to use local regional therapy in our center.
I do think Ashraf's question is to combine both the local regional treatment with the systemic therapy.
And that would be another option if this patient had larger intrahepatic burden, is to combine local regional and systemic therapy, understanding, although that can be helpful in some cases, and there's interesting early data, there are no large studies showing currently a benefit to do so. The trials of TKI plus local regional therapy have largely been negative. I think the trials of IO plus local regional therapy are promising, but still awaiting the phase 3 data.
Okay, look, Dr. Tamer, you had a question?
Yeah, if possible, yeah. Just a small question.
Okay.
I would like to ask Professor Singal, while we are in our MDT clinic, we are facing a patient with a large tumor burden, a large mass that may be taking half size of the liver with vascular invasion and with preserved liver function, and still we feel hopeful. While a patient presenting with a much smaller mass, but with bone metastasis or pulmonary metastasis, and we feel it gloomy and pessimistic. While both of them, I think they must be similar. Do you think they are similar in prognosis or different, sir?
Yeah, it's a good question. And so, basically, I think what you're asking is, within the BCLC stage C, so within this advanced stage setting, does it matter if you have vascular invasion or do you have distant metastases? Do we know if the prognosis for these patients differ, or is this just human nature where we think distant metastases are worse than vascular invasion? We know that the combination of vascular invasion and distant metastases, those patients do worse than patients with one or the other. I think the difference between distant metastases and vascular invasion, although there is some small differences, it's much smaller. So I think that, I think what we're going to, this is my sort of thought process here, is that I think that more than the baseline tumor burden, vascular invasion versus distant metastases, there's probably other tumor features which will bear out that will be more prognostic, particularly in terms of responses to, immune checkpoint inhibitors or Lenvatinib, et cetera. And I think those are going to be more important than just a baseline tumor burden. I think it's human nature to think that distant metastases are worse, but I don't know if that's necessarily the case. Once again, I'd be interested to see if others have other perspectives on this, but that's my sort of interpretation of the data I've seen comparing vascular invasion and distant metastases. Combo is definitely worse if you have both, but one or the other, I don't think the prognosis is dramatically worse with vascular invasion versus distant mets.
I think in the coming years, when we have more biomarkers, this will be determined, I think, better.
Yes.
Because it will be according to the behavior. You can justify your choice whether to treat this or not to treat that, and whether distant metastasis is a poor prognostic factor in this case specifically or not. So I think it will be easier for us to just maybe in the coming few years, I think.
Yeah. And, the biomarkers don't just have to be blood-based biomarkers.
Yes.
It doesn't just, there's a lot of, everyone has imaging. And our ability to use radiomics is becoming more and more complex. And none of these radiomics models have been validated, but there are interesting radiomics models that have been developed. And so this is readily available information that we're not using for all of our patients. And so I think once these have become validated, I think there's going to be some likely combination of radiomics features plus minus some blood-based biomarkers that, to your point, will become, and I know Professor Iman's said this a few times, is we'll become much smarter about our approach of saying this is the best therapy, this is your individual prognosis, rather than 20 months across the board.
Actually,
I think sorry,
Mohammed, I have a comment for Dr.
please
Usually the patient, as I see from the practice in the hepatoma group, the patient with distant metastasis, yes, it actually differs from the patient with portal vein invasion. The patient with portal vein invasion, the tumor behavior is more aggressive and the patient died early. I had never seen a patient that died from or because of the distant metastasis. The patient maybe gets a lot of mets, outside lung mets or whatever, but the patient didn't die because of it, even if lymph node metastasis or something like that. This may be also to the additional factor of worsening of the liver condition itself, the liver function. It's not just the tumor, but it's the liver function. Portal vein invasion by itself, even not malignant, will deteriorate the liver function. And in the case of the set of malignant disease, it will be progressive. It will never be regressive. That's why I see these patients are more worse than the others.
And one thing just to add on that is, particularly given the fact that many of the patients that were found to have large varices or had bleeding on atezobev had main portal vein invasion. So, going along with that, that may be another factor. Is it may actually determine some therapy eligibility for those patients with vascular invasion having more significant portal hypertension, not only in terms of risk of liver dysfunction, but therapeutic eligibility.
Okay, on the same line, don't you think that the evolution of biomarkers would take us back to taking more biopsies and checking the tissue biomarkers themselves?
Unless we can have accurate cell-free DNA. So, I think that, everyone's trying to get to liquid biopsy.
Yeah.
So I think it depends. It's a matter of how sophisticated we become. If we can really perfect liquid biopsy, then hopefully we prevent this in terms of going back to biopsies. But your point's well taken that, there's a chance that if we find something tissue-based that can't be replicated elsewhere, we may end up doing more biopsies. Our current clinical practice is not to do this for clinical purposes because there's nothing current. But I do think from a research perspective, there's a lot that can and should be done, in terms of using research biopsies for us to think of personalized medicine.
Mm-hmm. Well, I think we ran out of time. Yes.
We don't have any more questions from the floor. Any comments from our professor? So if you don't have...
I think Professor Sengel, last question. What about, is there any comparative studies about the cost effectiveness of Lenvatinib versus Sorafenib?
I'm sure there have been cost effectiveness analyses comparing Lenvatinib and Sorafenib. Of course, it depends on the health system in terms of the actual cost estimates for those. I think many of the cost effectiveness analyses have been done, using U.S. Healthcare systems. I'm not sure if there's been cost effectiveness analyses using, out-of-pocket costs or other sort of assumptions from a payer perspective. But I don't know unfortunately, I don't know the data offhand in terms of the cost effectiveness analyses, but I do know that there have been some that have been done.
Okay, thank you.
I don't know if anyone else has if they know the actual study.
Yeah.
Okay. It's my pleasure to close this magnificent webinar. And we can see all that we are still in Egypt facing a big problem with hepatocellular carcinoma, even after elimination of HCV. We didn't talk about the MAFLD, the NASH, and its role and what we will see from that. And we know that the screening that we did in 2018, we discovered that more than 35% of our population having a body mass index over 35. So they are obese. So we are facing a big problem even after elimination of HCV. And the key for the success is early discovery of cases of hepatocellular carcinoma and working through a multidisciplinary team, as we see from all our presentation now. At the end, I wish to thank Professor Sengel, Professor Barakat for very interesting sessions and very interesting presentation, and to thank Professor Elbaz and Professor Brady for their cases, and to thank Dr. Negma and Dr. Kordi for moderating this session. Of course, I have to thank Professor Walid Al-Adlati, who was behind all this activity. And of course, I wish to thank Newbridge Pharma and Dr. Alaa Dos for their support to this educational webinar. And of course, ICOM for a very elegant logistics and presentations. Thank you very much, and we hope to see you all again. And I have to say that the USHID conference will be from September, the last day of September and the first 2 days of October this year. And we are waiting for all of you to share with us in this. Thank you very much.
Thank you. Thank you, sir.
Thank you so much.
Thank you, Professor. Thank you so much. Thank you, Professor.
Thank you.